I guess I'm audible. So welcome all to today's talk on IIMA CMH's Virtual Healthcare Research Seminar by Dr. Valentin Bolotnyy. Sorry if I didn't pronounce correctly.
Oh, that was great. Thank you.
Okay. Thanks. So he is currently affiliated with the Stanford University's Hoover Institution. He does work on public and labor economics. And he also PhD from Harvard University and also a BA in economics and international relations from Stanford University. So today he is going to give a very interesting talk on the topic goes as graduate students' mental health, lessons from American economics departments. So I guess given the time that we are in, it's probably one of the most important topics that one could come up with. And I think there is a lot of learning that would be there for all of us. So I'm sure all the listeners will enjoy the talk. And personally, I'm very interested in the idea because I also went through these American economic schools, and I have seen my friends who often let me just put it this way, that there were sometimes issues that would pop up. So I'm very curious to look at the data that Valentin, you are analyzing and the insights that you come up with. We will have the talk for 1 hour, and there can be questions. I will request all of the listeners to, if you have some questions, please feel free to write in the chat box. And if and when some questions are piled up, then maybe I'll request Valentin to take them up. So thank you, Valentin. Very warm welcome here to you.
Thanks very much, Anindya, and Chirantan as well for the invitation. It's great to be here with all of you, and thank you all for spending your Friday nights with me here discussing this topic. As Anindya mentioned, not the easiest one, but an important one, especially for our times. This is work that's joint with Matthew Basilico, who's now at Johns Hopkins School of Medicine, and with Paul Barrera, who's at the Harvard University Health Services. What I'll do today is tell you about our motivation for the project and our objectives, what we sought out to do with this study. I'll let you know how we structure the study and what the surveys look like. It's essentially a survey-based study. I'll tell you our mental health findings and walk you through some of the work experiences that we measure throughout the study and the connections that we make there to student mental health. And I'll do my best to end on a positive note with some recommendations and suggestions for things that we can all do as students and faculty and administrators to improve graduate student mental health. And I very much am interested in hearing about your experiences and learning from all of you as well. So look forward to the Q&A, please, as I'm going through this. Think about questions and that you'd like to ask and things you'd like to discuss. We got going with this project at the end of 2016 in a kind of crisis moment in economics in Cambridge. I was a graduate student at Harvard at the time. Matthew Basilico was as well. We were in the third year of our program, and a fellow student at MIT had committed suicide, someone in the third year as well. So big shock to all of us, and it led to a lot of reflection on behalf of the students and faculty. It led to town halls and a lot of thinking around what we can do to make sure this doesn't happen again, what we can do to understand the anecdotes that sometimes would pop up about students having a hard time. Was that widespread? What was the nature of mental health issues in these graduate programs? Were we alone at Harvard and MIT in having these issues? And as economists, the steps that we would take to measure this, to get a sense of this, would of course be to collect data and to do some analyses. So what we decided to do initially was to do a pilot in the Harvard Economics PhD program, which turned up really interesting results, a lot of which are going to be repeated here in the study that I share with you, that ended up being a study across economics PhD programs. And our objectives were to understand the prevalence and the severity of mental health issues in economics PhD programs writ large, to understand better the experiences that students were having in these programs, and to see whether there were any potential connections between these experiences and student mental health. And finally, to make recommendations on steps that programs, students, and faculty can take to improve student mental health. The survey that we ended up running, or actually ended up being a set of surveys, was supported and encouraged by the American Economic Association's executive committee. They became interested in the results of our pilot at Harvard and wanted us to expand the study to other programs, and we were happy to do so. We ended up reaching out to about 15 departments in the US with the support of the executive committee, to the department chairs and to the faculty, deans of graduate study. And we had about 8 programs volunteer to participate on this with us. The main part of the study was a student survey that we sent out in the fall of 2017. It's 25 minutes in length, so pretty sizable. And we didn't offer any sort of incentives for students to take the survey. It included clinically validated instruments that measured the prevalence and the severity of mental health conditions, and I'll go into depth on what exactly those are and how powerful they are. And we also included questions about student academic, health, and personal backgrounds, as well as their experiences with their peers, with research, with advising the department. I'll focus my talk on the results of the student survey from fall of 2017. We also did a parallel short survey for faculty in the fall of 2017, and we did a follow-up for students in spring of 2018, which was also short. I'm happy to talk about those in detail, and I'll might mention some results from those 2 surveys as we go along, but the focus will really be on that fall 2017 survey. And it's also, I think, worth noting that this is all in the, as Claudia Golden likes to say, the BC era, the before coronavirus era. So keep that in mind as I'm speaking. My sense is that the current crisis is only exacerbating some of the issues that we measure here. The 8 programs that participated were UC Berkeley, Columbia, Harvard, MIT, Princeton, UC San Diego, University of Michigan, and Yale. So these ended up being some of the top-ranked, economics PhD programs. So keep that in mind as well. That this perhaps is not representative of all economics PhD experiences, even in the U.S. And certainly around the world. And that's actually something that a number of colleagues are trying to get a better sense of, and so studying mental health around the world now in these economics graduate PhD programs. We sent out the surveys to 1,138 students and received responses back from 513 for a 45% response rate. As you can see, fairly representative across these programs. No one program is really fully dominating the sample. It's about 10 to 15% of responses from each program in making up the whole set. In the panel A here, want to point out that we had about, these are, so panel A are the enrolled numbers in these programs. 28%, just if you're also interested in general for the makeup of these programs in the US, 28%, 28.5% of the graduate students are women, 50.8%, about half are graduate students who did their undergrad in the US. And that's all, those rates are also fairly stable across the years in the program. So also keep in mind that we're not doing this over time, right? This is one snapshot. So these are different cohorts of students in years 1 through 6 plus. And the shares are fairly stable across these years, right? So this is, again, I want to emphasize these are the enrolled numbers. We had about, and there are about 45% of students that responded. Panel B, just to give you a sense of our participants, so we're oversampling women. 35% of the sample were women, and that ranged from about 30% to 39% across the years. And we were also slightly oversampling U.S. undergraduates. That's important because women and U.S. undergraduates end up having slightly worse mental health numbers in our data. And so you could say that perhaps we have slightly higher mental health prevalence rates, mental illness prevalence rates than would be representative of these programs in general. And I'll go into some estimates, some alternative estimates, some steps that we take to make sure that our data is representative. So this is just something to keep in mind. What do we mean when we talk about mental illness and mental health disorders? I think it's important to cover this briefly before we get into the results. We don't mean stress in the kind of day-to-day sense that we often mean it. We also don't mean that someone is sad or upset about something that's happening. We sometimes use the phrase, "this is depressing," to describe a sad or upsetting situation that we're finding. We're talking about something considerably deeper, in particular a psychological state that is affecting several elements of our mental processing in a characteristic manner. So for depression, this is something that's affecting one's mood, one's memory, beliefs about self, sleep, appetite, psychomotor functioning, the ability to even get out of bed in the morning, and scores of unknown other factors. To also put it in kind of economics terms, there's productivity loss that's associated with these states. I'll go into the PHQ-9 more in just a second. That's a tool that measures the severity of depression, and every additional point on the scale is a productivity reduction of 1.65%. So sizable productivity reduction as a result of finding oneself in this state. The states are also real in that they're not they're biologically visible, and we have evidence from neuropathology, from neuroimaging, from genetics, from endocrinology that show an individual's biology changing in response to finding oneself in this state. For many, they cycle in and out, and it's not a static state, but a dynamic state. And it is often treatable, something that I think is very much worth emphasizing here, and something I'll come back to in my, certainly in my recommendations. The states are socially endogenous. It's not just genetics or just environment, it's the interaction of the two. And we know quite a bit about the environmental contributors that lead to, that push people into these states, contribute to these states. Is it a choice? The best analogy that I think is helpful here is a fight or flight response. Some people might have a stronger response, some people might have a lighter response when faced with a particular environmental situation, but it is rarely something that we fully have control over. And so, probably unwise to blame someone for finding themselves in this state that we will explore here further. The first state that we dig into is depression, and we do so in our study with the patient health questionnaire, with the PHQ-9. It asks, over the last 2 weeks, how often have you been bothered by any of the following problems? And it lists these 9 problems, and asks students to let us know, were they bothered by these problems? Not at all, over several days in the past 2 weeks, more than half the days, nearly every day. And the questions range from having little interest or pleasure in doing things, feeling down, depressed, or hopeless, having trouble falling asleep, feeling tired, having a poor appetite, all the way down to having thoughts that you would be better off dead or of hurting yourself in some way. So pretty explicit questions about how people are feeling, and at the end including also a question on a very direct question on suicidal ideation. Why do we use this tool? Well, it's commonly used in the psychiatry literature, and it's something that it's a questionnaire that a patient would receive upon coming in to see a psychiatrist. So something that a psychiatrist looks at before having a meeting with the patient and before issuing a diagnosis. And it is also highly predictive of diagnosis. So it's a measurement of symptoms, right? That's important for me to mention, that we're not actually able.
You want to take a question from Tarun? He has a query.
Sure. Yeah. Mm-hmm.
So Tarun, please go ahead. Tarun, you raised hand. Do you have a question or? Okay. So he needs to be unmuted. Mini, can you please?
Yeah,
I have already done that.
Okay.
Yeah, I've just been unmuted. So my question is that, these questions in these questionnaires seemed very explicit. So was there some, first, did the respondents have a sense of that these are the sort of questions that would be asked? And second, did you have like trigger warning or something like that when you were conducting these surveys? And did like people not complete the survey for any reason at some point?
Yeah, so we had a consent form at the very beginning of the survey, and you could see it. It's in the appendix of the paper. We include all the surveys that we run. The very first page that a student saw was a consent form that was very also explicit about what students would be asked in the survey and what its purpose would be. We had that also in the email that they received. So students understood that we were going to be measuring their mental health. We also had faculty, the department chairs, about a week before we sent out the surveys. We had them email students and say, this is coming, and this is what you should expect. So we think that we had primed students pretty well to expect these sorts of questions, and they did not come as a shock when they were seeing them in the survey. We didn't have that many students, fill out 5 questions and then see this and then drop out. So most students filled out the whole thing. We had some students who did not answer. So not all of the 513 participants filled out this particular question. Many just clicked next. So we do have some missing data throughout, but most students went through the whole survey and went from start to finish.
So on that, there is another question which was actually asked a few minutes back, but maybe there's an appropriate time now. The question is, can there be a selection bias amongst those who responded? So I guess the query is, given the nature of the questions, does it reflect some kind of only part of the distribution which might be somewhat measured.
Absolutely, and I will. So and I hinted at that at the beginning with the fact that we're oversampling former U.S. undergraduates and women. I'll go into some alternative estimates for our prevalence rates that we measure in a couple of slides, and we can discuss this further if people have more questions. That's a good question, certainly. So we're measuring the prevalence of depression symptoms, not diagnoses per se, but symptoms here with the PHQ-9. These symptoms, however, are predictive, highly predictive of diagnosis. So with about 90% probability, someone who scores 10 or higher on the PHQ-9 will, upon seeing a psychiatrist, be diagnosed with depression. That's something to keep in mind here as I show you our results here. What we're doing on the left-hand side here in the left column is dividing up the PHQ-9 into different score bins. And we're particularly interested here in the percentage of students that are falling into the 10 PHQ-9 score or higher categories. As you can see, we have about 18% of all the students in our survey experiencing moderate or severe symptoms of depression. Women slightly more, have a slightly higher prevalence than men, and former U.S. undergraduates have a slightly higher prevalence than those who did their undergrad abroad. For comparison, the CDC reports a prevalence of these symptoms of 7.7% among adults in the US aged 20 to 39. So there you can see that we're about 2 times, these symptoms are about 2x more prevalent in our graduate economics population. For all ages, that prevalence rate is 8.1%. And we can also do comparisons across other graduate programs. At Harvard, motivated by our work, the administration has taken on what they're calling Graduate Student Mental Health Initiative, where they've now surveyed using very similar tools over 40 students in over 40 different programs. And there, the prevalence rate that they're finding is 21.6%. So from the perspective of the general population, economics graduate students are doing considerably worse in the prevalence of these depressive symptoms. But compared to other graduate students, and there are other studies across different graduate programs at other universities and other programs that find rates in the 20% range as well. Relative to those programs, the economics PhD program seems to be doing better. We also focus on anxiety, which is these symptoms are highly correlated with depression, and this questionnaire is structured similar to the PHQ-9. It's called the GAD-7, also commonly used and also has that same predictive power as the PHQ-9. Here, questions range from symptoms of feeling nervous, anxious, or on edge, not being able to stop or control worrying, worrying too much about different things, trouble relaxing, and feeling afraid as if something awful might happen. And there's a similar scoring structure where students get between 0 and 3 points for each symptom, depending on how severe and how common these feelings are for them. So with the GAD-7, we're measuring very similar prevalence rates to depression, and that's to be expected because it is highly correlated with depression. Different mental health disorder, general anxiety disorder, but highly correlated with depression. Again, 17.6% of all of our students are experiencing moderate or severe versions of these symptoms. Women have a higher prevalence, and U.S. undergrads have a higher prevalence. Compared to numerous studies of U.S. adults over the last 25 years, were about 3x here of these symptoms, but again, doing better than graduate students writ large. To get into some of the questions around selection, what we did is we developed a couple of other estimates. So in the second column here, we're throwing in gender weights into our prevalence estimates to get us better sense of what would the population prevalence rates be. As you can see, they are somewhat different, these numbers, but fairly comparable to what I just showed you. Country weights in the third column, based on the demographic information that we have about where students did their undergraduate degree, they move our estimates even less. And in the last two columns, we tried to undertake this exercise where we assumed kind of worst case scenarios about the representativeness of our study. So in the second to last column, the lower bound estimate, what that does is it assumes that everyone else who did not take our survey is scoring below 10 on the PHQ-9 and below 10 on the GAT-7. So do not have these moderate or severe depression or anxiety symptoms. And what we see there is that even in this extreme scenario where our survey is really unrepresentative in that particular way of those who do not take our study, we find that about 8% would be suffering with depression symptoms and 8% with anxiety disorder. That is still higher than the general US adult population. So even in those extreme scenarios, what we're finding are prevalence rates that are higher than what we would find in relevant groups in the general population. One other thing that I want to point out to you here is our measure of suicidality over a 2-week period. That we're focusing on the last question of the PHQ-9 that asks very explicitly about thoughts, students having thoughts that they would be better off dead. And we're finding that 11.3% of students say that they've experienced those kinds of thoughts over a two-week period on at least several days in that 2-week period. It's considerably higher.
Valentin, regarding this very sensitive natures of these questions,
Yes.
There is a query on whether the literature says anything about whether such sensitive surveys should be self-administered or conducted in person.
Yes.
That's a question from Aishwarya. So any comments on that?
Yes. So these questions are, these are commonly used in kind of appointment settings, right, where a patient is about to see a psychiatrist or is seeing a psychiatrist. There have been numerous studies across in academia and elsewhere of different populations that have administered these questionnaires with the proper disclaimers at the beginning. So it's we offered students resources at the end of our survey and at the beginning as well, and we emphasize that if these questions triggered any particularly difficult thoughts, that they should reach out to us or to various mental health resources that they have on campus and elsewhere. So we really tried to make sure that we were not doing any harm with these questions ourselves.
And there is another sort of a claim. I don't know how true that is. Visheka is asking, or rather saying, that maybe anxiety could be a weaker condition of depression. I don't know whether that is true or not. So you can tell us a bit about that. And he says compared with the numbers of depression, but numbers for anxiety seem very small. So I guess the fraction of people saying that they're depressed, if there is a correlation, strong correlation between depression and anxiety, then probably the number of people who are anxious should ideally be higher. So what is the nature of correlation between anxiety and depression, and how should that reflect in this kind of scenarios?
Yes, so the correlation in our data, I believe, is about 0.6. It's a little higher in some other surveys that we've seen. So it's not, it's not 1, but it is a high correlation. And we're seeing, so if you just look at studies overall, the U.S. adults, the prevalence rate of these anxiety symptoms is about 6%, and of depression, 7.78%. So these anxiety symptoms are a little less prevalent than symptoms of depression. So in that sense, depression, these depression symptoms are more common in the general population. It's hard for me to say, that whether these anxiety symptoms are kind of a lower form of depression symptoms. I don't think that's the right way to think about it, honestly. Certainly the severity, the scales work in increasing severity of issues, and I don't think it's for example, someone who's experiencing feeling of being afraid as if something awful might happen nearly every day. It's hard, I think, hard to say that that's less of a serious issue than some of the things that we measure on the depression scales. Wanted to underscore that we are measuring considerably higher prevalence rates of suicidal ideation in our population. 4% of U.S. adults say they're experiencing this sort of ideation, and 7.4% of U.S. adults aged 18 to 25, the highest risk, highest prevalence group in the U.S. So we're considerably higher in our estimates. We can also look at these prevalence rates across years in the program, so across our cohorts. And what I want to emphasize here and point out here is just how much the last years of the PhD programs differ from the first years in the prevalence of these moderate to severe symptoms of depression and anxiety. We have about 14.5, 14.6% of the first years experiencing depression, 12.2 experiencing anxiety, compared to 25%, 28% of those who are in year 6 plus, 25%, 21% of those who are in year 5. The rates are fairly stable for years 1 through 4, but really climb up in those latter years. So, that's, of course, there are these are different cohorts, right? And that's important to keep in mind. Perhaps there's selection in these different cohorts. And we'll turn to that more on that in a second. But there does seem to be this sizable jump in these issues towards the end of people's programs. We can look at, we also collected information about whether people know that they've been diagnosed with a mental health issue, and whether they've had that diagnosis before they started the program or after. This is, getting to some of that selection that I just mentioned. If we look at the first row of the table here at the top, 13.3% of our first year students are coming in having had a prior diagnosis of mental illness by a mental health professional. So they've seen a psychiatrist and they're telling us, I've had a prior diagnosis. Perhaps the fourth years are somewhat selected on being particularly having these pre-existing mental health issues. But as you can see, for example, those in the years 6+, they're coming in with about the same prevalence as those who are in year 1. And generally, we're looking at prevalence rates, 10 to 13%. We then, in the second row, can see the percentage of students who were diagnosed during the program. And here, naturally, with every year, the later cohorts are going to have higher prevalence rates because they've been in the program longer. There's been more time for them to be diagnosed. But still, it's, I think, striking, especially of those in year 6+, we have 30%, an additional 30%, right, on top of the 13% that come in with a mental illness diagnosis. An additional 28.8% say that they have received this kind of diagnosis during their program. The percentage of people that say they're currently in treatment for mental illness. So good thing is that it's increasing as prevalence rates increase. So a larger share of those in year 6 are in treatment than those who are in years 1 and 2 and 3, for example. But what is troubling is that of those who we're seeing experiencing these moderate to severe symptoms, right? So people who, if they were to see a psychiatrist, would likely be diagnosed with a mental illness. We're at best seeing 35% of those students receiving treatment. And of the first years, 14%, only 14% are receiving treatment. That's it's at least it's good that we have students who are receiving treatment, and likely the rates are increasing because prevalence is increasing, because exposure to resources in a campus environment is increasing with the years in the program, and all of that is good, but these rates are still quite low. To give you a sense, compared to Harvard graduate students and the study that's been done there, overall econ students, 25% with these symptoms are in treatment, compared to about 41% across other graduate programs. So even compared to other graduate programs, economic students are less likely to be seeking treatment when they're experiencing these moderate to severe symptoms. And that's when also about half as likely as adults in the general US population with these symptoms to seek out help. Yes, and so in terms of diagnosis also, we are about as likely as the group with the highest prevalence to have a diagnosis. So those adults in age 18 to 25 are the most likely to receive a diagnosis, and we're at about that same rate. But I think it's important to underscore that you need to see a mental health professional in order to receive a diagnosis. And so we think that we actually are seeing a kind of lower bound on diagnoses here.
There's a question from Tarun. Tarun, please go ahead.
So, I'm curious that we see a 0% diagnosis in the first year of the program. That pretty much means that no one seeks mental health. Is that like in economics?
I should clarify.
No student goes out and seeks mental health.
I should clarify. So we did the survey in November, and so what this is essentially saying is that students in their first 2 months of graduate school have not received a diagnosis.
Okay, thanks. So,
yeah.
And is it, do any of these programs conduct screenings or counseling, or give out information that this is how you can say contact an on-campus counselor or anything like that?
There is a university-wide effort as a part of orientations to let students know of all the resources that are available to them. But it usually is not, mental health is one of 20 different things that these students are being told about. it's certainly, in our experience and talking to the faculty and administrators at these programs and at these universities, it's certainly not something that has been heavily emphasized as it often is for undergraduates. Undergraduates will have, they will have peer support, mental health support, mentors within their dorms. They will have active conversations about mental health. Universities, by and large, have not made as heavy of an emphasis on graduate students when it comes to mental health so far. That's changing, and I think we're helping contribute to that, and encouraging students to do some of these screens, to seek out, even have initial conversations with psychiatrists at the beginning of their studies, to get a sense of what it means to receive mental health support. Having faculty make an emphasis on this being a major issue, mental health care being important. That's something that is in our experience, somewhat new of a thing that the departments and universities are really emphasizing for graduate students.
Can I ask a small follow-up question? You might
Please,
get to this later, so feel free to punt if required. So, do we know what students in general do to cope? Like, apart from seeking professional care, what are all the other ways in which they might be coping, either with explicit like mental health issues or just like stress and anxiety that comes from the program?
Yes, that's a great question. We have some evidence of those different mechanisms that we collect. Mostly, it seems like it's family and friends, and that of course raises the important point that it's important for students to have family and friends that they can reach out to for support. So, and this is something that is found in a lot of other prior work, that social support in people's personal lives is crucial, and in fact that is the first line of defense. That's something that comes up first before students seek professional help. And so that's something that we have echoed here. Whether there are other channels, I think that's important to study further. Thanks for your questions. So to sum up our key mental health findings, we're finding that moderate to severe symptoms of depression, anxiety among economics PhD students is about 2 to 3 times as prevalent as in the general population. Suicidal ideation is 1.5 times as prevalent as in the highest risk group in the general population. And on somewhat of a bright side, these symptom prevalence among economics students is better than among graduate students writ large, but econ students are less likely to seek this kind of formal mental health treatment when facing these symptoms than students in these other programs. And we also ask, how likely would you be to seek mental health professional help if faced with a mental health issue? 45% say that they would be unlikely or only somewhat likely to do so. So there's stigma, reluctance, perhaps barriers to access that econ students are facing and seem to be facing at much higher rates than other graduate students even. We're also finding that the prevalence of these serious symptoms is highest in the final years of the PhD, and I think strikingly, 23% of students in year 6+ say they've experienced suicidal ideation in a 2-week period. What I want to do now is dive a little bit more into the kinds of experiences that students are having in their PhD programs, and then to connect it back with what we just saw on mental health, and try to piece together mechanisms and explanations for this puzzle. What's important is that what I'll show you in many of these instances are correlations, right? Correlations between certain work experiences and student mental health. We don't have causal claims to make here. We have suggestive evidence, sometimes preponderance of suggestive evidence, that mental health is perhaps causing some of these experiences that students are having. Certainly the effects could be going any which way here, and that's important to remember. So I think the biggest takeaways are there, as from what I'll show you, is that there are links, there are strong links, and causality is something that certainly future work should dive more into. We asked,
sorry for the interruption. Just so you know, you have 15 minutes.
Great. Okay. Yeah. Okay. So yeah, I'll maybe go a little bit faster through this and make sure that we have time for more questions at the end. So we asked students about sources of social support. Number of people that you can really open up to in your life. How often do you share a problem or worry when you experience it? Do you have very good friends in your economics department? How competitive are your peers? We were trying to get a sense at this sort of social support network that I mentioned. In the two columns, the last two columns of the table, we're showing correlations of the people's responses to these questions with their depression scores, anxiety scores, and suicidality. And suicidality scores. What we're finding is that more social support, more good friends in the department leads to lower scores, so better mental health, is connected to better mental health. Having more competitive peers is associated with worse mental health. Meaningfulness of work also shows up as important or as tightly connected to mental health. Do the students feel like they're able to use their talents fully? Do they feel like they're making a positive impact to their community or society? Do they feel like they're doing useful work? That's also related to mental health. We're seeing, so importantly here, I think, students generally have sources of social support. That's what we're finding here. There's some sizable, numbers of students that say they don't. So about 6% say they have nobody that they can really open up to. And that's important to keep in mind. When we look at meaningfulness of work, feeling of doing useful work, 28% say they rarely or never feel like they're doing useful work. These are more sizable numbers, and also point to something for us to focus on when we think about graduate research. Perceptions of faculty care. Do your advisors care about your research? Do they care about you as a person? That's highly correlated. Having faculty that care more about your work is connected to better mental health. Generally, students are finding that faculty care about their research and them as a person, but again, there are some sizable percentages of students that do not have those experiences. We asked about a range of difficulties that students are experiencing and how honest they think they feel like they can be with advisors about this. So being able to be more honest with your advisors is related to better mental health, but interestingly, across topics, right? Across research progress or talking about non-academic career options, mental health, all of these things have these correlations with better mental health. And here, what I want to point out, if you look at research progress, about 40% of students say they can't be honest at all with their advisors about difficulties they're experiencing in research progress. That is basically the same percentage of students that say they can't be honest at all with their advisors about mental health. So, if, you could make the point that advisors, they shouldn't be worried about student mental health. That's not kind of in their purview. But I think very few would make the case that advisors shouldn't be there to have honest conversations with students about research progress and to help on that front. And we're finding that those are similarly difficult subjects to broach for students. Teaching and preparing for the job market, the ability to be honest and discuss those topics with advisors are similar. But it's mental health, it's research progress, it's non-academic career options that are really places where students are having issues talking to their advisors. What's not correlated with mental health? The frequency of meetings that students are having with their advisors. So I think here, big emphasis that I would make is it's not the quantity of meetings, it's not the quantity of these relationships per se, it seems to be really the quality. A couple of other things that I want to emphasize here, seminar environments. A lot has been said about this recently. We asked how comfortable would you be voicing a thought in a seminar setting. Here, what I want to point out is that 35% of men say they would be moderately or very comfortable doing so, compared to about 19% of women. And this, even though how certain would you have to be about the high quality of a thought before you voiced it in a seminar setting, men and women say that they would have to feel similarly confident about their thoughts before voicing them. So, you could say perhaps women have a higher bar for what it means for something to be high quality enough that they would share it. But I think also it's worthwhile thinking about the kind of environments that we have in our seminars, usually that make women less comfortable participating than men. And lastly, we also asked about sexual harassment using a tool that the American Association of Universities has used. And we're finding that 21.5% of women, female graduate students, say that they've experienced sexual harassment in the department. And U.S. undergraduates, former U.S. undergraduates, are also similarly likely to have experienced sexual harassment in the department. To summarize, in echoing previous literature, we're finding that strong social support, having meaning and purpose in your work, that's negatively correlated with mental illness. Here, we're very much finding what the rest of the literature has found. Quality of advising relationships is more important than frequency of meetings. And it's just as hard for students to talk about mental health with advisors as it is for them to talk about research and non-academic jobs. So the professional piece here is also really important. 80% of women feel comfortable participating in seminars, and 80% of women feel uncomfortable participating in seminars, and more than 20% have experienced sexual harassment in the department. I want to end now and turn to any remaining questions on the topic of where do we go from here. Here's just kind of a list of things for us to work on, and that's something that I'm happy to discuss further. We think it would be good to make a big point, especially at the beginning of programs, about the seriousness of mental illness and the importance of mental health care, raise awareness of the prevalence of these issues and the characteristics of these issues, make it clear to students that, especially as they're entering the program, and of the issues that their peers in previous years have experienced. Decrease stigma of treatment, point to other graduate students that are accessing this treatment. Increase collaboration and sources of quality of social connections in programs. Encourage students to build friendships with their peers, and invest time in that as much as we encourage students to focus on their studies. Encourage those kinds of social connections. Improve advising relationships so that advisors advise in addition to evaluating. I think have the sense that the reason students have these difficulties broaching topics like non-academic careers and research progress with advisors is that advisors are serving dual roles as advisors and as evaluators, and it seems to be that we're going too much on the evaluative front. So perhaps one way to do this would be to introduce an advisor who is a volunteer to advise a student on purely advise students, not be an evaluator, purely help them navigate the program, and do that at the beginning of a student's program. help students find meaning and purpose in their projects, have regular conversations with them about whether their work is giving them meaning and purpose, and how much they care about the work that they're doing. That seems to be important, and it's certainly also echoed in prior literature. And working on seminar and departmental culture, also something that we think is important to do. And here are some more concrete suggestions, some of which I've already mentioned, and I would just say that here, last point is that it's also worthwhile for departments to really work more closely with campus mental health services for interventions, things like cognitive behavioral therapy, how to build a growth mindset, and to improve access to mental health services for students. Thanks. Would love your questions.
Thank you. That's a very interesting talk and very interesting data set as well. So we have some time to take questions. Can you see the chat box? So there is a question. It says, did the research establish significant differences in depression behavior between native English and non-English speakers?
Yeah, so we tried to get at that in a couple of ways. We asked explicitly, is English your native language or is it not? And we also tried getting at this with this, did you do your undergrad in the US? Did you do your undergrad abroad questions? We generally find that native English speakers and those who, similarly as I showed you, those who did their undergrads in the US, they generally have higher prevalence of mental health issues than non-English speakers or those who did their undergraduates abroad. So I should say everyone here, right, is an English speaker. It's more about what their first language is. Yeah, and that's something I think that needs further exploration. What exactly is the reason why these students are having these different experiences?
So there is a follow-up question, and I also have something very similar in mind. The question goes as, are there similar studies for PhD students from other areas? How are the findings different from the studies? So for example, can be hard sciences like physics, chemistry, and mathematics, or maybe there can be software, other subjects. But I would also like to piggyback on this question to ask about I guess you don't have data on it right now, but is it correlated with the job market prospects and also this idea of qualifiers, which are held at the end of the first year or second year, and so on?
Yeah, so we don't find correlations with students' first year grades. So it doesn't seem to be that mental health is correlated with grades in the first year. Mental health later in the program, I should say. It doesn't seem to be correlated with grades in the first year. It doesn't seem to be correlated with the how much students care about getting tenure, how much they care about getting an academic job as opposed to a private sector job, what they value, what they prioritize in life. It also doesn't seem to be correlated sorry, I should say is similarly correlated. So someone who says, I really value my family is my top priority, those folks have a similar prevalence rates as those who say that they really want tenure at a top academic institution. It seems to be affecting everyone across the priority spectrum. We, as I showed you, prevalence rates for depression and anxiety are generally higher in other graduate programs and studies that have been done across other programs. We did see that when we looked at, we asked students about regrets. What do you regret about your PhD program and your trajectory? There, we found differences between economists and those who are in the natural sciences or in engineering. So the natural scientists and the engineers, they are more likely to regret their area of study or who their advisors are. probably because they're assigned to a lab and perhaps they're stuck with it for the duration of their study. Economics PhD students seem to have more regrets about how they've spent their time, how they've managed their time, and how much they've invested in their studies. So we're kind of, I think, finding in terms of structurally, for the natural science and engineer students, it's perhaps those advising relationships and thoughts about whether they went into the right field or not that are really dominating issues of concern. For economists, it's the lack of structure that seems to be the biggest issue that they're struggling with. Both could be causing mental health issues in their own ways, but those are some things in terms of environmental experiences that we're finding different across PhD programs.
So there is one question on whether stereotypes and gender roles could contribute to this mental health challenges. And there is a follow-up question on whether fellow students differentiate between the students who have mental health problems and those who take treatments and so on. So basically, the question is if there is a stigma associated with it, which is stopping people from getting treatment. Yeah.
I think, certainly on the gender stereotypes front, it's certainly something that would be affecting people in the way that they experience their programs and the way they interact with their peers. And I think similarly with the second question, in the way that stigma can deteriorate social and personal relationships, right, and deteriorate those sources of support that students need, especially in these difficult times, that could be certainly contributing to worse mental health outcomes, could be contributing to students not seeking help. That's, I think, certainly part of what's going on. In some programs, these issues might be more pronounced than in others. It's something that I think we're actively working on. We're talking to programs about ways to break down the stigma, and even you all inviting me here today and my ability to share this work with others, encourage this kind of open conversation, understand that these issues are common and serious, and unfortunately, with recent events in the economics profession, hopefully all of that is decreasing the stigma as we are having more conversations about it and realizing that this isn't something to take lightly or to dismiss, and that this is common, that we all are at some point likely to suffer versions of this. We're hoping that chips away at people's reluctance to seek help and get treatment.
I just have a query on this last point that you made. Mm-hmm. Regarding stigma, given that these are, in terms of, let's say, education, this would be maybe, I don't know, like very small fraction of people who would be on the extreme right tail of educational attainment and so on. Is the stigma, if there is this kind of ideas, so if I am thinking that I should consult a mental health professional, a counselor to get help, and then if I am thinking that other people would judge me in a different way, is there a way to differentiate between how much of it is perceived by the person who is supposed to take help and how much of it is really out there in the peer group, for example? Is there a way to differentiate, or this is almost impossibly confounding?
Yeah, we weren't able to do that. It's and certainly seems like a hard problem, because certainly with a survey that is self-reported, right? So it's hard to hard to differentiate between perception and what is actually happening in the community. For practical purposes, even if this is caused by pre-existing mental health issues, right? In some sense, the perception is really what matters, because that's what's affecting student behavior and the way that students interact with these programs. So I think focusing in on those perceptions, whether through actually addressing the environmental issues or through helping students see that actually the environment is friendly and you shouldn't be concerned, you shouldn't be worried. There could be many channels through which we try to get at that, but it's improving those perceptions that I think is important. And yeah, this is where experimenting, working with campus mental health services, I think is particularly valuable. They have experience dealing with this across the university, with very different groups of students, undergraduates, graduate students, or professional students. And, they, in many cases, they certainly should be thinking about different ways of reaching students, different ways of ensuring confidentiality and privacy. We found, at Harvard, for example, some of these partnerships have resulted in people from campus mental health services coming in and doing cognitive behavioral therapy sessions, doing conversations around building a growth mindset, and with faculty encouraging participation in those conversations. All of that has, the more we've kind of embraced mental health services and it being completely, the more that is officially talked about, the less the stigma is there, we think.
Do you have time for another question?
Yeah, absolutely.
So others, feel free to write on the chat box, or maybe now you can unmute yourselves and ask questions directly. I just have one more question from my side, which is that in the recent times, I'm sure you would know about this, that a lot of these issues have come up mostly in the social media, including and also problems related to economic seminar series, as well as how people talk to each other on online anonymous forums, which are often very specific. Some forums are very specific to economics, for example. During your this whole survey, was there any question on how these students interact in terms of engaging in social media, online, or with full identity or anonymously, or was there any questions on that front?
We didn't ask about that in the way that you're interested in. We asked how often do you use Facebook or other social media, and mostly what we were interested in there is there's been prior work that's shown that students that or individuals that spend a lot of time on social media, perhaps that's crowding out some personal connection building in real life. And so we did not find correlations there with the mental health of our students. And it doesn't seem like these graduate students are spending inordinate amounts of time on Facebook or on social media. That said, that was in 2017. Things are moving fast. So certainly Twitter seems to be a place where the students and faculty are spending more time. And I think that especially also in this coronavirus era, what is this kind of isolation and just removal of personal connections doing to us? I think that's something that's worth exploring further. Prior evidence and the recent findings from the CDC is suggesting that it's certainly it's worsening mental health issues. Yeah.
Okay, so there seems to be one more question, and maybe after that we can end the session. The final question from Pallavi is there any correlation between academic performance and mental health similar? Is the correlation between academic performance and mental health similar for US undergrads and non-US undergrads? This, I think you're talking about.
Yeah, that's a good question. I don't remember off the top of my head what we found there. Yeah, I will go back and take a look at that myself. But I don't remember. My sense is no, but I don't hold me to that. That's something that I need to check. But overall, for the whole student population, we did not find a correlation. With first year grades specifically. We don't have information on people's job market outcomes. Yeah.
Okay, so great. Thank you all for attending this very interesting talk and very important as well. So I'm sure you will be updating your data sets and a lot of new insights will also come in. Thank you a lot, Valentin. It's very useful, and probably we in our institute also would like to implement some of your suggestions, and I'll ask Chirantan to send your paper to the concerned people. So thank you very much for giving us time to listen to your talk, and it was a pleasure to have you here.
Thank you all very much. Great to be with you, and yeah, certainly look forward to future conversations. Yeah, thanks again.
Thank you very much.